Thank you for that kind introduction. So today for the Pain Science Series lecture, we're going to be covering platelet-rich plasma and stem cell therapy, looking at the past, what we've done, what current therapies can be used for, and where the future is going to go with these technologies. And just to reiterate, this presentation is going to be recorded and we're going to have a Q&A session at the end. Just a little overview of what we're going to be covering. We're going to start off with what is PRP, like how is it created, how does it work, what can it be used to treat, what does the patient actually experience and feel during the procedure, how long does it take for the healing process to actually kick in, any risks or side effects, the costs as well. And then we're going to switch gears, look at stem cells, and cover a lot of the same stuff: how it works, its role in treating certain pathologies in chronic pain management, what that procedure is going to feel like from a harvesting the stem cell perspective and also receiving the therapy, risks and side effects, and we'll also touch base on some finances as well. So without further ado, let's dive right in. What is PRP? So platelet-rich plasma is a concentrated form of your blood that's packed full of growth factors that can promote healing. Patient essentially just has their blood drawn. The sample is then sent to part of the lab where they have a centrifuge and it's spun to separate it into the different cell layers. The layer that contains the most platelets is then drawn up into a syringe and this is injected into the patient. These platelets contain all these different growth and healing factors, and when we concentrate them in the solution like this, we're actually getting about 5 times the amount that you'd find in a normal vial of whole blood. So this is like just packed full of these growth promoting healing factors. The concept of platelet-rich plasma has been around for literally decades, and we've used it in different forms of medicine, from surgery to wound healing and even hair growth over the last 50 years. So there has been a decent amount of research that's been done in this area. It's most commonly created through 2 different processes, which we're going to talk about. However, there's no really consensus preparation protocol at this time. We're going to talk a lot more about that later because it's one of the biggest barriers to doing good quality research for this. But it also depends on what the PRP is going to be used for, and that's going to guide how it's prepared and ultimately what is contained in the final preparation. But in general, broken down into 3 steps. First, collect the blood from the patient. We normally get about 10 to 60 cc's of blood, and then it's added to this tube that has a medication in it that's going to prevent the blood from clotting. After that, it's spun in a centrifuge, and just like I said earlier, it's going to separate into those 3 distinct layers. Then we're going to withdraw that platelet layer, and at that point, during some cases, you're ready to inject. Some clinicians also apply like an activator agent. Not everybody does. It is not standardized, and it's not even required for this stuff to really still pack that healing punch that patients need. So this is a little schematic that kind of overlies like one of the 2 most common methods for preparing platelet-rich plasma. Pictured above, this is what's called the Buffy coat method. And in this Buffy coat method, we take the whole blood from the patient, centrifuge it at a really high speed, and then you can see that purple layer in there. That's the platelet layer that has all those extra platelets, but it also contains white blood cells, which are responsible for having all these effects in your immune system, from regulating inflammation to fighting off infections. This is another diagram that illustrates the second most common preparation method, and this is considered the pure PRP method. And in this form, you're going to extract the blood, you do a soft spin in the centrifuge. That separates it into the first 3 layers that we talked about. And then you're going to transfer that platelet-rich layer into a different vial, centrifuge it again, and now you're going to get these even more concentrated platelet pellets. Those pellets are then usually drawn out of the vial with a syringe. Maybe they take a little bit of the extra serum with it as well so that you have a larger volume of injectate so that it'll spread better and you're ready to go. Of note, since this like preparation is slightly different than the Buffy coat, we end up with a totally different final product. When you do the Buffy coat method, you're going to have those white blood cells in there versus this method, those are just platelets. There's no other red blood cells, there's no other white blood cells, and they have different uses, and we're going to talk more about that later. This slide is more just for your general information. It's a little bit too detailed for the scope of this presentation, but the take-home message is that there's a lot of different ways of preparing PRP. And depending on how the medication's actually prepared, that's going to have a big effect on the composition of the end product. This is important because different types of PRP are utilized for different types of problems. For example, in the world of dermatology, utilizing a PRP product for hair growth, they would prefer to have a pure platelet-rich plasma solution with the thought that having less of those white blood cells in the final preparation is going to reduce the risk of having an unwanted skin reaction after injection. Versus if like you're in the world of orthopedics and they're using platelet-rich plasma like after a knee surgery or something like that, and they want to inject it in there to help with healing, they're commonly going to use platelet-rich plasma that contains leukocytes or those white blood cells or this platelet-rich fibrin, a second generation, because the thought is when you add those extra white blood cells and you're injecting into an area that's already been operated on, maybe they're going to give you some antimicrobial effect that's going to help you prevent infections as well. So really, it depends what we're using this for. That's going to guide how we prepare it, and ultimately the final product that the patient's going to be receiving. And I wanted to get a quick video of what this process may actually look like of them harvesting the blood and then making the PRP in office. I am going to mute myself for this video because the music is a little overwhelming, but this video was sourced from Precision Care, Medical, and Sports Performance. So here. So,
Dr. Ladd, I just want to check, were we supposed to hear something audio-wise from that
oh no,
video? No.
hopefully not.
Okay.
You didn't hear that music.
No, we did not. Okay.
It's for everybody's like benefit that you didn't hear that. But as you can see from this incredibly high speed video, this is not a super time intensive process. The entire appointment can range from just 30 to 90 minutes. The most intensive process is actually when they spin it in the centrifuge itself. That alone can take up to 30 minutes at times. Overall, not bad. It's a same day procedure. You should be in and out of the clinic relatively quickly. That's why I skipped it. So, how has PRP actually been utilized in chronic pain? It's now recognized as a treatment option for ligament, muscle, and tendon injuries, as well as peripheral nerve injuries and even osteoarthritis. The current research focused on how well PRP works for these different issues. It's inconclusive at this time. There's just too much variability in how these procedures are actually prepared, which in effect determines the final end product. And that makes studying this stuff very, very difficult. It's really hard to extrapolate and apply this data from these studies when ultimately they're giving a different medication each time. It's one of the biggest barriers to having this be truly FDA approved and having insurance coverage for it, because we have all these single studies that are showing benefit, but they can't be reproduced because they're technically using a different medication. You can see where the issue comes in. Oh, I lost my presenter view. So, PRP for osteoarthritis and cartilage defects. Cartilage lines our joints and it's going to reduce friction and also provide cushioning. But over time, the cartilage can wear down and we can get that bone on bone grinding interaction that causes this progressive inflammatory state that we all know as osteoarthritis. The cartilage in our joints, it doesn't have a very good blood supply, unfortunately. So as you can imagine, once it's injured, it's really hard to transport blood and nutrients into that area for it to actually begin to heal. Animal studies on sheep, rabbits, and rats have demonstrated that PRP has the potential to help regrow areas of damaged cartilage, reduce inflammation, and also prevent the death of the cells that are actually creating the cartilage in the first place, thus kind of halting this progression of osteoarthritis. I'm gonna quickly see if I can get my presenter view back up. Well, it says it's there. PRP for osteoarthritis and cartilage defects continued. So in 2020, Elkstons et al. Published a study where 20 patients received PRP and then the other 20 patients received steroid injections for knee osteoarthritis. Both groups had improvements in the pain and knee function, but the greatest improvements in the pain scores occurred at 3 months for the PRP group and at 1 month for the steroid group. The PRP group also went on to show sustained improvement in pain up to 7 months, even to a year later, while the steroid group started to worsen again after about 15 weeks. Steroid effects were starting to wear off. The improvement in knee function was observed in both groups, at 5 to 15 weeks, and there was no statistically significant difference in like the outcomes between PRP versus corticosteroids. Also, so PRP for tendon and ligaments continued. Thank goodness it has been used and researched in this area because we have literally thousands of these structures throughout the body and they're commonly injured. Tendons are strong muscular tissues that connect your muscles to your bones. Over time or with injury and overuse, the tendons can degenerate and become inflamed, a process that we know as tendinitis, or they can even rupture, like an Achilles tendon rupture. These tendons do possess a limited ability to heal on their own, but this process is really slow and it can be limited in the later stages of the disease or in instances where there's been a complete tendon rupture. Ligaments, on the other hand, are dense fiber structures in the body, and these are the guys that connect bones to other bones and form the joints in our body. These also possess an ability to heal, but it's so slow. We're talking on the order of like weeks, months, even years to overcome this stuff. So it's oh, wish we had something that could actually help this. I am going to try to get my presenter view back up so I can see my notes very quickly. Excellent. We're in business. So the short answer of these things with how long it takes to heal this stuff, what if we had a technology that would actually help? We're working on it. Achilles tendon injuries are very common in a wide range of patients, so naturally a lot of research has been done in this area trying to see if PRP would be helpful. Achilles tendon injuries are common in both aging population and also young adults. Sanchez et al. In 2007 found that athletes who received PRP in addition to conventional surgical repair, they showed earlier return to sport and moderately increased tendon thickness following recovery. And rotator cuff injuries in the upper extremity are also some of the most common shoulder injuries that we encounter. Unsurprisingly, PRP has also been utilized in this area. In 2013, Ra and colleagues conducted a randomized single-center study to evaluate the effectiveness of PRP injections for treating rotator cuff dysfunction. After a 6-month follow-up, the PRP group showed better pain relief and improved range of motion. PRP was also found to be safe, and it's also worth noting that none of those patients that received that in the study ended up with any adverse side effects. PRP has also been utilized in more serious orthopedic injuries. Some of the most serious involve the anterior cruciate ligament, or the ACL. When that thing is torn, the standard of care for patients who still live an active life or have active knee instability, it's surgical repair. Mahdi and colleagues conducted a study with PRP following surgical ACL repair and found at 3 months, the PRP group had improved integration of that graft with the bone, so the healing process was enhanced. And although the data for PRP use in all these musculoskeletal injuries is promising, there's also loads of data that indicates that it's not effective. Further research needs to be conducted to validate these studies that have been done before this stuff gets paved for FDA clearance and insurance coverage. For instance, there was a study by Walter and colleagues that found that patients who underwent ACL repair with surgery, whether or not they received platelet-rich plasma post-surgery, they had similar levels of kneeling discomfort and patellar dysfunction as the group that did receive it and the group that didn't. So no real difference. PRP has also applied for nerve damage. These peripheral nerve injuries are a common cause of functional decline, sensory and motor loss, and even neuropathic pain, or pain that is coming directly from the nerves itself. Our standard of care, utilizing nerve blocks, burning these nerves away, medications, and surgery, it offers limited relief, but patients are often left wanting a little bit more. PRP contains these growth factors that are able to regulate inflammatory states in the nerve itself and create an environment that promotes nerve healing. Malachias and colleagues conducted a placebo-controlled trials, and it showed significant improvement in symptoms and sensory function after a single platelet-rich plasma injection into the carpal tunnel area of patients who had really bad carpal tunnel syndrome. So even with these like promising results, we still need to have a little bit of work done. But the upside is, it seems like there's a lot of different applications of what this medication could be used for. We've even looked into using it for painful diabetic peripheral neuropathy. However, the data is inconsistent here as well, especially when it comes to the different PRP preparations being used. So in some cases, like they used platelet-rich plasma that had high levels of platelet-rich fibrin in it. And those, like the animal models where they injected that medication in and those animals had nerve injuries, it actually hampered the recovery. This just goes to show that we need to do more research in this area so that we can fine-tune exactly what we're giving the patient so we can avoid any of these adverse outcomes that we want. We don't want that. Yeah, we just need a lot more research before this becomes widespread. Moving on to the more relevant information that patients should actually be aware of. What's it actually going to feel like? So the process of the PRP application, like I said earlier, done on an outpatient basis, and it's not that bad from a time perspective. The most painful parts of the procedure can involve when they place that initial IV so that they can draw the blood out. When they're doing the injection themselves, ultrasound guidance is typically used. And depending on where they inject, there can be discomfort. And a lot of patients actually complain of a sense of fullness. But injecting into like a larger joint, like a shoulder or a knee, can be less painful compared to injecting into a smaller confined space, like injecting directly into the Achilles tendons. But it's also worth noting that in patients who have chronic, long-standing pain in their knee, they may be hypersensitive to this because their central nervous system is just so used to receiving those pain signals. So injecting into something like that could be a painful experience. Talk to your provider. There are chances that these clinics in the area would provide procedural sedation if it was truly needed, and your provider is going to do everything they can to make sure you're comfortable throughout the process. So I just got my PRP injection and now my pain is worse. Discomfort, swelling, stiffness, and even warmth in the area after the injection is totally normal within the first few hours. It's actually an expected part of the healing process. That initial discomfort usually settles down in the first few days to weeks. So over the first week after the injection, there's a localized inflammatory response at the injection site. That just means the healing process has started to kick off. For that first week, the patient should just rest, minimize activities that are gonna provoke or exacerbate pain in that area, and try to avoid things that could hamper the inflammatory response, like steroids, icing the area, and non-steroidal anti-inflammatory drugs. Platelet-rich plasma has both inflammation provoking and anti-inflammatory effects, but the net effect overall is anti-inflammatory. Initially, it does create an inflammatory process to bring all these other cellular messengers that give healing factors to the area. They have to migrate there, so it does create a little bit of inflammatory effect to draw them in. After about the second week after the injection, the discomfort should start to decrease, but the area may still be a little stiff. It's okay to participate in gentle movements and light supervised physical therapy if that's what your provider deems is appropriate at that time. You want to help the body promote its natural healing response, so go out and walks, get good sleep, get some fresh air, eat healthy, do gentle range of motion exercises, but try to avoid anything that's going to hurt it. So weeks 3 and 4 after the injection, patients may begin to notice less stiffness and improvements in mobility. Pain should also continue to improve. Rehab with physical therapy should be introduced at this point. Avoid overexerting yourself. That's so important. So at weeks 5 and 6, pain should continue to decrease. Patients may notice improvements in strength in the injured area at this point, and you can return to moderate physical activity, but still try to avoid any high impact activity like sprinting or jumping, especially if the injection was in the lower extremity. You don't want to aggravate that. Week 7 and beyond after the injection, the pain should continue to improve or resolve altogether. Physical restrictions are fully lifted at that time, and the patient may return to either sports or their previous activity levels. I can't stress this enough. Continue therapy with the goal of incorporating long-term mobility and strengthening exercises into daily routine. This is not a panaceum or a magic pill that's going to fix everything. It's a valuable tool that should be incorporated into a multimodal approach to treat pain. How long is this actually going to take to heal? We already talked about how pain reduction in the area may occur as soon as 1 to 2 weeks. However, it's going to be variable. Depending on the type of injury you have, how severe it was, how long you've had that, the results may be slower, occurring over like courses of months instead of just weeks. And you may also need more than one injection, but we're going to talk about that. Functional improvements after PRP injections tend to also be slow. This medication needs time to bring into those healing factors and actually start to repair the injured tissues. So functional improvements plan for around like 3 to 6 months to be fully realized. And am I only going to need one injection? Depending on the underlying nature of the injury, it's totally possible that you could have symptomatic relief and functional improvements after just one injection, especially if the injury is new, it was mild in symptoms, versus something that is chronic, severe, very bad symptoms. You may need a little bit more in those cases. Um, with those more severe and older injuries, it's typically expected to be put on a PRP injection schedule by the clinic provider. Normally, they're doing 2 to 3 injections, roughly spaced 10 weeks apart, but there are no set guidelines that determine like the optimal timing of getting these repeat injections and how long you should wait in between. Just have a discussion with your provider because everybody's injuries are going to be slightly different. You should have a specific treatment plan tailored to your individual needs. There are some other factors that can determine like who is going to respond better and have better results at the end. Severity and chronicity of injury, I can't stress that enough. Huge factor. Younger patients obviously going to heal a little bit faster. And then your activity level and your adherence to those post-injection guidelines, that will also determine the results of your outcome. We get this one a lot. Is it possible to get too many injections? Since PRP is made from your own blood, it's technically low risk, but more does not always equal better. Overinjection is absolutely a possibility, and you can get increased discomfort, inflammation in the area without any additional injury healing. That's why it's important to discuss an individualized plan with your partner before you go down this road. Now, what can you do post-injection to boost your chances of having a successful treatment? You should really adopt a holistic model. We're going to take into account your nutrition and your lifestyle activities. From the nutritional standpoint, avoid ultra-processed foods, alcohol, candy, emphasize foods that contain vitamin C, omega-3s like fish oil, stuff like that, collagen-rich foods, which are listed on the side. And also, you can just discuss some nutritional supplements that have weak evidence for supporting improvement in healing. Things like magnesium, turmeric, curcumin, and collagen peptides may be beneficial. If you're going to be taking the turmeric or curcumin, wait at least 1 to 2 weeks before starting it because they can hamper that initial healing inflammatory process. And then I also get asked a lot, like, when can I start drinking? Or like if patients consume tobacco or cannabis, when can I return to those? And my thought process with this is you should probably stop it 1 to 2 weeks before. And then while you're recovering, until you hit that plateau and you don't see any more improvement, I would try to hold off from those. They can decrease that level of where you're going to get hit that plateau, and we want you to get as much improvement as possible before that peaks. As far as lifestyle activities, focus on getting proper sleep. It sounds so simple and easy, but there's a lot of things in chronic pain that can prevent you from getting a night's sleep. Do the best you can. We're going to try to manage our stress levels during this time to lower cortisol, especially after the first 2 weeks when we don't want that inflammatory process kicking off. Pain psychology can be utilized as an additional treatment to help develop coping strategies to help manage that stress and the pain that you're experiencing. Also, engaging in gentle range of motion exercises and supervised exercise therapy to promote further healing is paramount to having success with this treatment. So let's move on to the risks. Side effects include pain, swelling, redness, and bruising around the injection site. Essentially, anytime we violate the skin with a needle, always a risk of bleeding, infection, damage to surrounding structures. Call your provider though if you see any like signs that there could be an active infection going on. Fevers, chills, body aches. If your pain just starts to suddenly progressively get worse after the injection, like day 5 to 10, you're getting worse again, let your provider know. And obviously, if there's any like spreading redness from the injection site, warmth that doesn't seem to be going away after those first few days, or you have any obvious pus that is draining from that site, do not pass go, do not collect $200, call your provider. Something serious could be going on. Injections into areas with tendons and ligaments also has the potential to produce a self-limiting inflammatory reaction that makes movement uncomfortable for about 1 to 2 weeks. And although PRP is made from your own blood, allergic reactions are still possible and have been recorded in the literature. Always keep an eye out for that stuff, especially if you notice facial swelling or any difficulties with breathing. That could be an emergency. Oh, now for the fun part. How much does this stuff actually cost? Expensive. The therapy typically ranges from 400 to 3,000 forming the injection, and what their coverage is typically very limited with this procedure. The therapy is considered investigational, and that being said, it's a good idea to discuss pricing and payment plans with your provider at your first visit so you're not caught with an outstanding bill that you just didn't expect. Some private insurers like Aetna, Blue Cross Blue Shield, United Healthcare may provide coverage for certain injuries, but this is super, super rare. Cigna considers the procedure not medically necessary, aka they are not going to cover it due to lack of sufficient evidence to support its use. But there are things that you can do to try to increase your chances of having insurance coverage for this that I wanted to break down. These are like the pro tips for the patients. So to increase your chances of having this covered by insurance, work with your provider to gather relevant medical documents. This may include documentation of previous failed treatments, imaging findings indicating a specific injury that could be treated with platelet-rich plasma, or previous tangible success with the treatment before. Let's say you had this done, you paid out of pocket for it, you had tried all these other therapies, they'd all failed, you get PRP, and you have proof that, like, hey, this stuff works for me. Make sure that is medically documented, and those documents should be available to the insurance company as well. Still, no guarantees, unfortunately. So this is a screenshot from CMS.gov website directly, and I wanted to find out, like, can PRP be covered by Medicare and Medicaid? It can, but it's so difficult. To fulfill the criteria, there's only like one condition. Patient must have chronic, non-healing diabetic pressure and or venous wounds, and you need to meet the criteria. Patient has to be enrolled in a clinical research study that addresses very specific parameters, and the clinical study applications for coverage pursuant to this national coverage determination must be approved by August 2nd of 2014. In other words, super difficult to get coverage for. The studies, if you do have painful, like diabetic, non-healing ulcers, the study has to be examining complete wound healing with use of PRP, ability to return to previous function and resumption of normal activities, status post-PRP, or reduction of wound size or healing trajectory. It's really hard to get coverage with this stuff, but hopefully that improves once the research gets better as well. In the future, we're going to have more research that is able to actually show validated effectiveness of this therapy. Once we get that, that's going to open the door for insurance coverage. One of the biggest barriers to this is that there's a lack of standardization as we prepare this stuff. Once we get that standardization and the classification of these medications down, the quality of the studies is going to improve. And that means the quality of the therapy available to the patients is also going to improve as well. And hopefully it'll be covered by insurance in the future. I hope you guys are still with me at this point because we're going to quickly run through stem cell therapy, what it can be used for, all of that jazz. This one's there's less evidence. I'm going to leave it at that, but you'll definitely see. So, what are stem cells? These are undifferentiated cells, which just means they haven't made up their mind regarding what type of cell they want to be when they grow up. They play a vital role in forming organs during fetal development and also function by replacing and restoring various tissues in adults. The first stem cell transplant took place all the way back in 1957 when a healthy donor patient had their bone marrow cells infused into a patient with leukemia who had undergone chemoradiation therapy. Since then, stem cell therapy has been employed for a variety of pathologies, including Parkinson's, spinal cord injuries, and even advanced osteoarthritis. So the applicability of this treatment option to areas of chronic pain, it's definitely there. We just got to do a little bit more research first. There are also many different types of stem cells, but for the sake of everybody's sanity, I am not going to be performing a deep dive into the cellular classification system of stem cells. This slide is here to illustrate that there are multiple types of stem cells that can be applied to different areas of medicine. So, stem cell and pain therapy. It's been growing in popularity as an alternative approach for treating osteoarthritis, nerve pain, spinal disc disease, and certain musculoskeletal pain. But I'm going to give you the spoiler alert right here. We're not quite there yet, but we're going to talk more about that very soon. Oh, let's learn more about a familiar topic. So this should sound familiar. Let's talk about the cells that actually comprise cartilage and help secrete this stuff that cushions our joints. Those cells are called chondrocytes, and they're actually the only living cell in cartilage. And still, they only make up 1 to 5% of volume of the cartilage that's lining our joints. That means these cells are very sparse and they don't have a blood supply to give nutrients to the area. Now you totally understand why it's so difficult to heal these areas. But what if we could come up with a way to put more of these chondrocytes into the areas of damaged cartilage? Well, we tried that. They tried using these chondrocytes taken from one patient and injecting them into the knee of patients with osteoarthritis as far back as 1994. However, we learned pretty quickly that this stuff is not as straightforward as it seems. The chondrocytes that were injected into the other patient's knees tended to actually turn into a different form of cells, and then they created the wrong materials. It was a type of collagen, but it wasn't the right type. So it didn't have that cushioning property and it didn't reduce the friction the same. And it also caused the cartilage to grow in just this hodgepodge, unorganized manner. So it just wasn't accomplishing the jobs. There have been other animal and human research studies that have shown that stem cell therapy can help regrow cartilage, improve range of motion, and decrease pain. But to date, there have been no high-level evidence studies conducted that show that stem cell knee injections provide a significant and enduring benefit. And this area honestly has the best evidence for it. So yeah, take like everything else that I'm going to be saying with a grain of salt. Stem cell therapy has also been used for nerve pain. Um, the main idea is that these stem cells are going to release healing factors as well as providing a source for the replacement of those injured nerve cells. Again, research here, very mixed. There have been reports of stem cells being successfully used to treat nerve injuries, spinal cord injuries, and diabetic peripheral neuropathy. For instance, two groups of researching spinal cord injuries in animals found that subjects had less pain and recovered motor function after directly administering stem cell therapies into their spinal cords. However, there's also research that speaks about the downside and the possible adverse effects that you can have. They've also injected these into animal models where they had nerve injuries and the nerves did not grow back in the correct way. And in those animal studies, they showed that those animals then had painful nerve pain in the limb where the injection took place because the nerves grew in a poor manner, and then all they were doing was generating pain and causing something called allodynia, or pain that's caused by a non-painful stimuli. Things like touch, pressure, vibration, those were causing pain. So it shows like there are potential real side effects and the potential for worsening symptoms after these injections. We definitely need to do more research in this area before this stuff is ready for prime time. So diabetic peripheral neuropathy, this occurs due to the destruction of blood vessels. That's going to decrease the amount of blood flow that's going to an area. If those nerves get decreased blood flow, they don't have enough nutrients and they can die. Stem cell therapy is currently offered for this condition, but the safety and effectiveness still needs to be studied more. There was a meta-analysis, which is just a combination of all these different studies performed in 2025 by Kataria and her colleagues, and they examined 10 research studies examining the use of stem cell therapy for diabetic neuropathy, osteoarthritis, and even spinal cord injuries. And on average of those studies, most patients who received the therapy, their pain went down by about 2.5 points on a scale of 0 to 10. So there's definitely some promising signals there. We need to work on it. So Stem cell therapy for spinal cord injuries. Spinal cord injuries can cause patients to have intractable pain and huge functional limitations and disability. And then also, there's very few treatment options at this time. Depending on the type of injury that actually occurs, stem cell therapy could potentially play a role in the future. Keyword on future. A 2016 animal model review by Yusuf Fard and colleagues showed that stem cells have the potential to facilitate healing of the spinal cord when it's cut or it's bruised after a high impact. If there's like a contusion to the spinal cord, that's when the stem cells do have the possibility of potentially healing it. But if the spinal cord is like being compressed, like if you have narrowing in your spine and it's causing that stenosis, much, much harder to treat it. That same study found that if we have a spinal cord injury, the sooner we can treat it, that's when we're going to have the better results. For those spinal cord injuries that have persisted for years or even decades, that's a steeper hill to climb, and we're not there yet. Now for the practical stuff. So how are these cells commonly harvested? Most commonly, they go up into that hip that you can feel when you push down your side, and they actually take a needle and put it into there. That area is called the iliac crest. But the cells can also be harvested through liposuction, fat excision, and even umbilical cord blood. If you're going to have your stem cells harvested for medical use, a bone marrow biopsy in the hip region is typically performed. The process is usually tolerable, mild to moderate pain, thanks to anesthesia they give you during the procedure. I'm still going to run down what you can expect on the day if you are donating stem cells or having them harvested. So they'd bring you into the procedural suite, they'd expose that area on your side, you'd be laying down on your side, clean the area, make sure everything is sterile. Usually they'll put some drapes down as well to have a clean area to do the procedure in. Sometimes they'll use ultrasound to localize like where they want to hit the iliac crest. Other times, they will just numb up the skin with some lidocaine. After that, it should just be dull pressure as that needle gets down. Once it's getting close to the bone, that outer part of the bone does have pain receptors in it, and it's more difficult to numb up. They can give a little bit more lidocaine in that area to numb it up further. Otherwise, poke through into the bone. That's where the bone marrow is. Pull the syringe back. Now you have some stem cells that could potentially be harvested, replicated, and given to a patient. It's still very common to have pain, soreness, stiffness, and bruising in the area, harvesting for days to a couple of weeks after. But usually, if you take Tylenol, NSAIDs, you rest a little bit and use ice, most patients find it pretty tolerable. Depending on what is wrong, you may not even have to have your stem cells harvested. So they actually have done research and they found that patients who have advanced osteoarthritis, they are not good candidates for donating their stem cells. In advanced arthritis, that inflammatory process that is just progressively worsening actually decreases the amount or changes the viable stem cells that you produce. So you wouldn't want to be harvesting that patient's stem cells and injecting them into a patient. The patient can either receive allogenic or autologous stem cell therapy. So for autologous stem cell transplant, this is when we're using your own stem cells that we harvest from you and then give it back to you on the day of the transplant. Allogeneic stem cell transplant, this is when someone else has their stem cells harvested and then they are donated to a different patient who's getting the transplant. What's it going to feel like to receive this? And the answer is, it depends. Well, you are going to have an IV placed, so that's one poke that you can absolutely be sure of. But these stem cells can be administered in many different ways depending on the underlying condition. Sometimes they're injected directly into a joint, in which case it's going to feel like a normal joint injection or getting a flu shot. They can also be administered systemically to go directly through an IV and it'll go throughout your body. There's issues with that as well. The lung system will actually filter out a lot of those cells, and very few of them make it through the circulation through the lungs, and they're still viable, but I digress. They can also be given intranasally through an inhalation, and stem cells have even been injected directly into the spinal cord through a lumbar puncture. So depending on the underlying problem, that's going to determine what is the best way to administer this medication to the patient. Ask your provider in advance what route the medication is going to be given to you in, and they should walk you through what to expect on the day of treatment. You don't want to be caught like you show up and they're like, oh, we have to do a lumbar puncture for you, and you didn't plan for that. You should ask about that. So, what to expect post-stem cell therapy. Receiving the stem cells is usually only mildly painful at worst, but some patients will still experience discomfort and fatigue for a few days following. After an injection, they're probably going to monitor you for anywhere from 30 to 90 minutes just to make sure you're not going to have any of those rare adverse reactions, like an allergic reaction or anything like that. You should expect some mild soreness and swelling at the injection site for a few days, and Lalu and colleagues in 2012 and then Wang in 2021 showed that roughly 8 to 13% of patients also experience a low-grade fever, fatigue, and skin irritation following the injection. But these side effects, they're generally transient, it's just temporary, and they usually resolve within a few days. If you began to experience these same symptoms like a week out after the injection, totally different story. In that case, I would reach out to the provider that did the injection and be evaluated to make sure that I'm not developing an infection. So regarding the healing process after treatment, these cells need to migrate to the area of injury, attach to the site in a very specific way, replicate and turn into the appropriate cells, divide, and then start releasing the healing factors they need to rebuild the injured tissue in that area. In other words, this is going to take a while to kick in. Improvements in pain, range of motion, and stiffness are generally thought to occur over the first 1 to 3 months, but the healing process can occur over 6 months to even a year, depending on the severity and how long you had the injury beforehand. Some patients will continue to experience improvements in pain and function for years to follow. So who shouldn't get this therapy? It sounds like it'd be great for everybody. There are a couple absolute contraindications, which means definitely don't receive this. If you have a known allergy to any of the components in the medication, this is not the treatment for you. If you have an active infection at the injection site, don't let them inject into an infection. That's just a big no-no. You're going to spread the infection. It can be serious. Or if you haven't been consented for the procedure and you don't understand what the process entails, that's also an absolute contraindication. Knowledge is power. You should have a good understanding of what this procedure is going to feel like, what it's going to look like, what are the risks, benefits, and alternative treatments that are available for you. Relative contraindications to stem cell therapy include the use of blood thinners or having a bleeding disorder that could make the injection dangerous. If you have an active or you're being treated for a cancer, there's a theoretical risk of cancer formation with stem cell therapy if these cells were to theoretically turn into the wrong cell and then replicate uncontrollably. I don't think that I would go for that treatment option in that case. If you're immunocompromised or you're on strong immunosuppressive drugs, this is also a relative contraindication. So any post-transplant patients as well, this is more risky and probably not something you should be having done on the outpatient basis. That should be taken care of at a large hospital inpatient. If you're pregnant or breastfeeding, there is just no data that shows how these stem cells will affect pregnant and breastfeeding mothers and their child. So, like, contraindicated. And any severe organ dysfunction that could make the procedure dangerous. Think things like advanced lung disease where you're on chronic oxygen, or advanced heart failure where the ejection fraction is really low. All of those could make the procedure more dangerous to have this performed in the outpatient setting, especially if you're receiving sedation during the procedure. Probably not a good idea. How do you increase your chances of a successful stem cell therapy? It's going to be very similar to the PRP. Optimize your nutrition, stay well hydrated, manage stress, get plenty of sleep, and the best results occur when this therapy is combined with physical therapy and pain psychology. I cannot stress that enough. Avoiding alcohol and tobacco products and cannabis leading up to the procedure. Stop at least 2 weeks before. Try to limit these for that first 1 to 3 weeks or until you hit a plateau, like we talked about with your improvement. Take it easy and limit the excessive use of the area where the injection occurred, at least for the first 48 hours, and start incorporating light physical therapy at your provider's discretion, walking and other gentle exercises after about 1 to 2 weeks. Around week 3 to 6, you should begin a formal physical therapy plan. The best results come when this is combined with other therapies. Week 6 and beyond, you can return to your previous activity levels. Okay to start strength training. You're still likely going to continue to benefit from doing physical therapy moving forward. So, what are the issues that we currently have with stem cell therapy? Patients with advanced osteoarthritis, like I talked about earlier, those stem cells are depleted or deranged. Those patients, not the best donors. The exact cell concentration dose, whether to apply the stem cell systemically or to a local source, and the best cell source for each specific treatment is currently under investigation. As you can tell from that, there are so many variables at play. So it's really hard to put together a study where it can then be replicated by multiple providers across the country and we can all compare our data. Without that reproducibility and standardization, the studies just lack a lot of power to determine is this therapy truly useful? And that's why all these therapies are considered not medically necessary or investigational. And stem cells also tend to migrate away from the injection site. And when I first was preparing this presentation, I thought that I was going to be presenting to my attendings. So I actually did a very deep dive into the basic science of PRP and stem cell therapy. And I'm going to nerd out for 1 second because I thought this was so cool. And it also shows like where the future of this research is going. So since these cells tend to, like you inject it into a knee, it migrates away. How do we get around this? They're literally using electricity to create these micro and nanofibers in a process called electrospinning. And this creates a cell-friendly environment in the form of this nanoparticle scaffolding, which then the cells can then attach to and grow in this very organized manner. It literally can determine what cells these stem cells are going to turn into, what materials they're going to produce, and it can even give them nutrients. It's just a really cool area of research that's needed before this therapy is ready for prime time to help those patients with osteoarthritis around the world. So, risks. Patients should also be aware of the risks associated with stem cell therapy. We already talked about whenever a needle goes into the skin, bleeding, damage to surrounding structures, infection, but stem cell therapy does come with other potential risks. There's a possibility of patients developing worse pain after the procedure, and there is a potential for this pain to be long lasting. The stem cells can also potentially be recognized as foreign invaders by your immune system, which means that could set you up to have an autoimmune attack, and that could be very serious. There's also that theoretical cancer risk that we talked about if these cells were to turn into the wrong cells and then replicate uncontrollably. And if we don't use this scaffolding and we inject this stuff in there, there's a possibility to have bone, nerve, and even scar tissue form inappropriately and just lose the original function of the joint, organ, or tissue that it was intended to have. Red flags to look out for post-stem cell therapy. Allergic reactions are very possible, so any issues, especially face swelling, difficulty breathing, take that very seriously. Go to the ED. Progressively developing severe pain or decreasing functionality in the injection site should also be brought to the attention of the provider. Patients have reported new onset neurological deficits following injections, which can potentially be medical emergencies. Any notable discharge from the infection site? Absolutely. Spreading warmth, redness in the area could be an infection. Let someone know. Oof, this was an interesting topic to look into. So, the cost of stem cell therapy. This stuff can become so expensive so quickly. The cost for a single injection or a single treatment, 2,000 to 8,000 USD. Very expensive. And if multiple injections are planned, like you have a severe or very old, long-lasting injury, it's not uncommon to reach 20,000. I saw quotes online in the Bay Area for $50,000 for a series of 3 to 4 injections. I was like, who can afford this? That's crazy. But factors like where the stem cells are coming from, how many injections are needed, whether or not image guidance is going to be used for the treatment process, all of those can quickly add up and create a very expensive treatment plan. I actually get this a lot. So with the cost approaching $50,000 in some clinics, this has opened up the opportunity for clinics outside of the United States to cash in on this opportunity. People will commonly travel out of the United States, like to Central, South America, Europe, to receive these injections for just a fraction of the cost. And although that treatment may be way cheaper elsewhere, the treatment process may not adhere to the strict FDA guidelines that are in place in the United States. These more loosely regulated treatment facilities have resulted in poor outcomes for patients that I've personally cared for during my graduate medical training. when I was doing my anesthesia residency, I actually had two patients over the course of my 4 years that ended up in the ICU due to receiving a stem cell transplant at a clinic outside of the country. And one of them got such a severe infection, it attacked his heart, and he ended up having to like receive open heart surgery. So that just goes to show the potential for this stuff is like it can go wrong, and the fallout from it can be serious. So just be careful. Make sure you trust the clinic that you're going to, and just ask a lot of questions. They absolutely should adhere to the strictest aseptic guidelines. You want this stuff to be sterile. There's always the possibility that some of the solution that before it's injected could become contaminated, and then you risk introducing an infection into the patient. Regarding insurance coverage for stem cell therapy, super variable, just like platelet-rich plasma. Among private insurers, the vast majority are not going to cover it. And since the majority of these treatments lack FDA approval, they're always considered experimental or not medically necessary. Just means it's not going to get covered. And with such extreme costs, it's vital that you check with your insurance provider beforehand before you actually get this shot, so you're not stuck with a massive bill that you did not plan for. Some clinics do offer financial assistance, so it may be prudent to ask the provider, like, hey, is there any financial plan that I can get on, be it a repayment plan or some type of discount? Definitely worth asking with these prices. Oh, so the future of stem cell therapy. It has a long way to go before this treatment is ready to be given to multiple patients throughout the country. The studies are just too inconsistent, and the procedure itself can be performed in so many different ways for a particular injury, making it really hard to put together a standardized study that can produce reliable data and then can be replicated by other providers. This therapy is still getting a lot of press and publicity. I wonder why, because it costs so much, despite the generally weak evidence that is currently available to support their use in multiple chronic pain conditions. There are extremely promising signals in this research that this could potentially be a game-changing treatment option down the road. We just need to do more work until we get there. I'd say 5, 10, 15 years, but continuing to ask questions to your providers to learn about the latest and greatest therapies and technologies, it's always worth your time to see if something is new out there that can help you in your individual problem. Here are my references. And while you think of questions, please enjoy these photos of my 7-week-old son, who was my biggest supporter throughout this entire presentation. He sat on my lap for like 16 hours over this weekend as I rushed to put some pictures and stuff together to make this look pretty.